Hello, and welcome to one more week in our Philosophy of Science of Nursing course. Um, Today, we're going to talk about process, philosophy, and theory of human becoming. So, this is a foundations for nursing knowledge. You'll notice on the first slide at the very bottom, it says Panta Rei. Does anyone know what this means or where it comes from? So just take a moment. The phrase is attributed to Heraclitus of Ephesus, and he's a pre Socratic philosopher who lived around 500 BCE. It means very simply, everything flows. Also, it's a title of a book by John Dupree, who's a philosopher of science. Everything is in motion and nothing stands still. Now, I want you to sit with that for a moment before we do anything else. Everything flows. If that's true, and today we're going to make the philosophical case that it is deeply and fundamentally true, then what does that mean for nursing? And what does it mean for how we understand the patients in our care? What does it mean for how we understand ourselves as knowers or as practitioners or as researchers? Today's lecture is not a lecture where I'm going to hand you a lot of facts to memorize. I know that everybody's glad when they get to their PhD program, and that's the case. This is a philosophical inquiry. We're going to think together. We're going to encounter ideas that may unsettle some assumptions you didn't know that you were making. And that's entirely the point. I want you to think of this class not as a knowledge transfer exercise, but as a conversation. A conversation that began long before uh, you turned on this lecture and that will continue long after you leave this course. I also want to say something about myself in relation to this material. I'm not a philosopher, so not the expert here. The river that Heraclitus said you cannot step into the same river twice because the river is always different, and so are you. That river is the field of inquiry. Every time I teach this material, it's different to me because I've learned something, I've experienced something else. I'm not the same now as I was even a moment ago. And I hope that today you'll encounter it for the first time, maybe, and that encounter will be worth your time. We have 5 major parts to cover today. Um, for now, simply notice that everything we're about to do is in motion, and that includes each of us. Let's review the learning objectives for today. So I'll go through these a little bit slowly and deliberately because objectives in a philosophy lecture are a little different from objectives in a clinical course. And these are not things you'll be able to check a box and say, yep, I've got that one, I can move on. These are kind of orientations. They're kind of a direction of inquiry that I want you to be moving in and out of like a river. So, learning objective 1 is articulate the core principles of process philosophy and trace their influence across nursing theory. So that means that by the end of this lecture, You should be able to explain in your own words and without all the jargon we tend to use what it means to say that reality is fundamentally constituted by process rather than substances. You should be able to trace a line from Heraclitus to Bergson to Whitehead to contemporary philosophy of biology and see how that line runs directly into nursing theory. That's the first objective. The second objective is to critically analyze Parse's theory of human becoming through process, ontological, and phenomenological lenses. This means you will not just know what Parse's theory says, you will be able to examine why it says what it says and what philosophical commitments make it intelligible. And you may be able to locate it within a tradition, which means you'll also be able to locate its tensions and its limitations. That's much harder than memorization and much more useful. And then, of course, learning objective 3 is to apply dialectical reasoning to deliverables in nursing epistemology. This is the one I want to spend a moment on. Remember, dialectical reasoning is the ability to hold a thesis and its antithesis simultaneously and to generate synthesis that genuinely moves the conversation forward. It's the philosophical skill I want you to get comfortable with this semester. It's not about finding the middle ground, and it's certainly not about being wishy-washy. It's about thinking rigorously through apparent contradictions. Today's lecture is structured dialectically. Each part builds on the previous one, but the synthesis only arrives at the very end. All right, so let's start with philosophical foundations. And I want to begin with a little intellectual biography, a story about three thinkers whose ideas taken together give us a conceptual vocabulary from everything else we'll discuss today. The first thinker is Heraclitus. He lived in Ephesus, which is what is known as Western Turkey today, around 500 BCE. And he was one of the most fascinating figures in history of philosophy for a very specific reason. Almost nothing he wrote survives. We know him only through fragments and through short passages quoted by philosophers that came after him, usually in the context of arguing with him. And I want you to notice something philosophically interesting about that fact. We know Heraclitus through his relationship with others. His ideas have come down to us not as a monument, but as a living conversation, which is, you might say, entirely appropriate for a philosopher who believed that everything was in process. His core insight is that logos, or the relational principle that's underlying all of reality, is change itself. The cosmos is not this static structure that occasionally changes. It's constituted by change. Fire was actually the metaphor he used. Fire is always becoming, always consuming, always transforming. Nothing in the universe is exempt from this process, including, of course, human beings. The second thinker is Henri Bergson. And he was a French philosopher who lived from 1859 to 1941. And he introduced the concept that will be central to our understanding of nursing. um, durée, which means duration. Bearson's insight was that there are two fundamentally different kinds of time. There is clock time, quantitative, measurable, the kind that requires us that that we use when we look at a monitor or when we check a pulse rate. And then there's the live time, which is qualitative, continuous, and cannot be reduced by numbers. Live time stretches and compresses. So a moment of pain might feel like it lasts forever, and a moment of joy might disappear instantly. Or if you think back to childhood, if you were waiting for Christmas and the gifts, or your birthday and the gifts, you know, it was one of those things that it seemed like it took forever. And then as you grow up and you get older and you become a parent and you realize, oh, it comes away too quickly. Bearson argued that Western science had systematically confused these two kinds of time, and that this confusion has been catastrophic and had catastrophic consequences for our understanding of life. Remember how different it feels. Remember back to your childhood, and it'll be easy to keep this concept in your head. So, another thing I want you to think about when you're considering this is if you can think of a moment in your clinical practice or in your own life when clock time and live time were really different to each other. Just a moment when the clock said 5 minutes had passed, but your experience said something entirely different. And then hold that example in your mind, and we'll come back to it. Now, I want to give you 4 specific conceptual tools from this process philosophical tradition. So, 4 ideas that you'll need to have clearly in mind as we move through the rest of the lecture. Think of these as the vocabulary of process ontology. And like all philosophical vocabulary, these words mean something quite precise. They are not the way we ordinarily use the words. So the first concept is ontological priority of events. In substance ontology, which is the default metaphysics of Western science in a world that is made of things that occasionally do things. So, a world made of things that occasionally do things. Nouns are primary and verbs are secondary. A person has experiences. A cell undergoes metabolism. The subject comes first, and the activities are attributed to it. Process ontology reverses this entirely. Events, so happenings, occurrences, or processes, are primary. What we call things are actually relatively stable patterns of process. So a cell is not a thing that undergoes metabolism. A cell is its metabolism. If the metabolic processes stop, there's no cell. There is only a structure that used to be a cell. So verbs are primary and nouns are abstractions. So let me ask you to feel the force of this. So you're going to have to slow down. You may have to pause the recording for a minute. Right now, metabolically, you are not the same person who walked into this lecture, who turned on this video. Your cells are exchanging molecules with the environment. The boundary between you and the room is a process, not a wall. So, what does that mean for how we define a patient? What does it mean for assessment? The second concept is becoming over being. This is the Bersonian point. Reality is not a set of static states that are linked by transitions. Reality is continuous becoming. What we experience as states are snapshots, useful fictions that kind of impose on this continuous flow. When we take a blood pressure reading, we're not taking a snapshot. That snapshot is clinically useful, but it's not the patient. The patient is not the continuous, the patient is the continuous process of which the snapshot is only a momentary cross section. So the patient's not just the blood pressure you just took, and they're not just the temperature, and they're not the IV you started. The third concept is relational constitution. In substance, ontology thinks exit first. So, if you think of it as something exists first, and then you think of it as they enter into relations, the relations are external. They connect things that already exist independently. So in process ontology, relations are internal. They constitute the things themselves. So you're not a person that enters into a relationship. You are, in part, constituted by your relationships. Your relationships are not something you have, they're part of what you are. Now, what does that mean for nursing care? And what does it mean for the therapeutic relationship? And then the fourth concept is stability as achievement. This may be the most counterintuitive and the most important for clinical practice. In common sense and in biomedical models, stability is the default. You are alive and your body maintains homeostasis, and that's kind of the natural state. Disease is the disruption and of that stability. So process philosophy reverses this too. Stability is not the default, it's an achievement. It kind of takes continuous work. So it takes metabolic work, it takes immunological work, it takes cognitive work, it takes relational work. And it takes all this work to maintain what looks like a stable state. Health isn't the absence of disease. Health is the successful ongoing achievement of coherent functioning in this changing world that flows. And when a patient becomes unstable, we're not witnessing a fall from a natural resisting state. We're witnessing the failure of an achievement that had been ongoing. So pause here and think. Which of these four concepts is most difficult for you to observe? Which one creates the most friction with how you're trained? And that is the one that I want you to pay the most attention to for the rest of this class. All right. Um, Now let's move on to classical philosophy, from classical philosophy to contemporary philosophy of biology. And I want to introduce you to the work of John Dupree and Daniel Nicholson. Um, their book in 2018, Everything Flows Toward uh, basically a philosophy of biology. And notice the title again, Pante Re, Everything Flows. It's one of the most important, in my non-philosophical view, recent contributions to philosophical foundations in biological sciences, of which I count nursing as one. And it has direct implications for nursing. Dupree and Nicholson center um, uh, basically their central argument is that biology has been doing something philosophically confused for a long time. And it's been treating biological entities as if they were the kinds of things that could be understood, from a snapshot. So, as if a cell or an organism or an ecosystem is the kind of thing that simply is and that can be studied by describing what it is at a given moment. Now, I kind of can relate to this because when I was doing my PhD in nursing, I did lab science and I was looking at muscle cells that had experienced carcinogenesis. And so I was actually taking snapshots of cells. So this kind of speaks to me. But this is the substance ontology applied to biology. And Dupree and Nicholson argue with detailed empirical evidence that this is wrong. Biological entities are not things, they are processes. So, um, I think nursing's kind of argued that about human beings for a long time. They're not things, they're not systems, but they're these holistic processes that come together. So they give us three motivations for this view. And I want to walk you through each one of those kind of carefully because they're each independent and make the case. The first motivation is metabolic continuity and turnover. So your body replaces most of its constituent molecules over the course of months to years. The most specific carbon atoms and the hydrogen atoms and the nitrogen atoms that make up uh, your body 10 years ago, they're almost entirely gone. They're now in the atmosphere and the water and other organisms. What persists is not the matter, but the organization. So the pattern of processes. You're not a substance with a fixed composition. You're a process that maintains patterns across continuous material turnover. Um, if that's true of the most basic level of biological organization, then what does it mean to treat a patient as a substance? And what are we missing when we do that? The second motivation is dynamic organization. So living systems aren't organized like machines, where the organization is imposed from outside and the parts are replaceable components. Living systems generate their own organization from within. They're what biologists call autopoietic or self producing. And autopoietic is fundamentally uh, basically a process type of concept. The organization is not a structure, it's a process that continually regenerates itself. So, um, in many ways, it's why we tell people get plenty of exercise, go to the gym, eat a healthy diet. You cannot you can't understand the body um, by looking at a snapshot of it. You can only understand it by looking at the process over time. The third motivation is biological individuation. What makes an organism an individual? In substance ontology, the answer seems obvious. An organism is a physical entity, and we're bounded by its skin. So, as humans, sometimes in Buddhism, we refer to humans as skin bags. Um, but this becomes philosophically complicated really fast. Your gut microbiome contains roughly as many microbial cells as you have human cells. So are they part of you? Your immune system's constantly negotiating the boundary between what's you and what's not you. And the boundary is a process, not a line. And as we know, sometimes when that boundary gets confused, then you have disease. Dupre and Nicholson argue that biological individuality is itself a procedural, a process achievement. It's not a given. So now I want you to think, which of these three motivations do you find the most challenging for biomedical models to accommodate? And I want you to hold that question, because we'll use it when we reach the comparative framework that's going to come later. But just hold on to that thought for a moment. Make yourself a note. Hit pause. So I want to give you a direct comparison, and I created this kind of basic table that might be helpful to you. And so it basically gives you kind of side-by-side views of substance ontology and process ontology that are applied to 4 core domains that are relevant for nursing. And I want you to do something a little different here. I'm going to walk through the left column first, the substance view, and I want you to recognize it. This is the ontology that most biomedical education assumes without naming it. It's not wrong. I want to be very clear that it isn't wrong. It's just limited. So the goal of process philosophy is not to abolish substance thinking, but to know when it fails for the person in front of you. So if you look at domain 1, what is a person? So in the substance view, a person's a biological organism or a psychosocial that has social properties. So it's a body, mind, and they're combined in this complex way that can be described and measured and intervened upon, as we do so often. And in the process view, a person's a continuously unfolding process of becoming. So open, creative, and mutual constitution with the entire world. the person's not a noun, the person's a verb. In domain 2, the question is, what is health? And in the substance view, health is a state of normal, stable functioning. So homeostasis that's maintained, deviations from normal are corrected. And in the process view, health is this ongoing, harmonious becoming, the successful navigation of change, the capacity to meet each new moment creatively. Health is the view. It's not a destination. It's the way of being in motion. Domain 3 asks, what is disease? And in the substance view, disease is a deviation from the norm, this pathological state, something that's gone wrong with the mechanism. So in the process view, disease is a disruption in the process of becoming. It's a pattern that has become rigid or chaotic or unable to meet the demands of the changing world. And notice, this shifts our attention from what's wrong with the structure to what's happening in the process. And then domain 4 asks, what is nursing care? So in the substance view, nursing care is the application of evidence based on interventions to restore the normal functioning. In the process view, nursing care is co-participating in becoming. So being present to the patient's unfolding experiences and accompanying them through it. So look at the substance view column, and think about which of these 4 descriptions most closely matches the discourse you encounter in your clinical setting, and which of the process view descriptions creates the most friction with the discourse. The friction's not a problem. That friction is where your dissertation lives. You may want to remember that. The friction's where your dissertation lives. All right, let me move on to the phenomenological and the cognitive science, and I want to introduce you to the work of Evan Thompson. Thompson's a Canadian philosopher. His most important book for the purposes is Mind and Life, and it was published in 2007. And he's one of the principal developers of the theory of inaction. Inaction basically is a theory of mind and life that argues against what Thompson calls the internalist picture of cognition. And that internalist picture basically says that mind is inside the head, and perception is the process of inputs and outputs, and cognition is what the brain does. So Thompson was building on the work of Francisco Varela and Humberto Maturana and Maurice Ponte. And he argues that this is fundamentally wrong, that cognition's not inside our head. Cognition's actually enacted, and it arises in this dynamic loop between an organism and its environment. Mind's not a thing in a body. Mind is a process that spans the body and the environment. So let me give you Thompson's own example of the bacterium. So I'm going to just read you his example. So a bacterium swimming up a sugar gradient is doing something philosophically remarkable. It is not simply responding mechanically to a chemical stimulus. It is perceiving the world in terms of its own needs. For the bacterium, the sugar is food. It has significance. But that significance is not in the sugar, and it's not in the bacterium. It arises in the dynamic interaction between the two. All right. Thompson calls this sense making, the capacity of living organisms to generate meaning through their engagement with the world. I would call that meaning making in the work that I do. So think about this. If even a single celled bacterium performs sense making, if even the simplest possible living system generates meaning through its engagement with the world, then what's the complexity of sense making that's being performed by a dying patient in the intensive care unit? And what meaning is that patient generating? What does it mean for us to enter that world without first asking what the world looks like from inside it? That is why Thompson's work is philosophically foundational for Parse, because Parse's theory of human becoming is, at its deepest level, a theory of human sense-making. It's a theory about how human beings generate meaning through their engagement with the world. And Thompson gives us the biological and the cognitive scientific grounding to understand why that sense-making's not a psychological overlay on top of the physiological, but it's constitutive of what it means to be alive. Now, building on Thompson, let's talk about the phenomenological arc of care. And this is kind of my own way of organizing insights from Thompson and Jonas that I find particularly useful for nursing practice. So let me walk you through it. So Hans Jonas, sorry, I said Jonas, but it's actually pronounced Jonas, was a German-American philosopher who wrote The Phenomenon of Life in 1966. His central claim is that life cannot be understood from the outside through this detached observation. Life must be met, it must be encountered as life, as something that's always already engaged with its world, always already caring about something, always already directed towards something that matters to it. Jonas' insight gave us the first move in the phenomenological arc, which was attunement. So to attune is to open yourself to the other's world before you begin to interpret it. It's not passive. It's an active orientation of receptivity. It's kind of a willingness to let the other's world matter to you before you decide what it means. In nursing, this corresponds to what Parse calls true presence. So a particular quality of being with another that's not the same as being nice to them or being technically competent or being empathetically attuned in the ordinary sense. It's a disciplined philosophical orientation. The second move is interpretation of meaning. So once you've attuned yourself to the other's world, you begin to the work of making sense of what you're encountering, not diagnosing and not categorizing, but interpreting. So what's the significance of what this person's experiencing? And what does it mean to them? And notice, this interpretation is not something you do to the patient, it is something you do with the patient in conversation and in dialogue. The third move is moving with the rhythm of becoming. And this is the most difficult to describe. It means that care is not a static intervention that's applied to a passive recipient. Care's a dynamic co-participation in the patient's ongoing process of becoming. The nurse moves with the patient, not leading, not following, but accompanying. So think about that. You're not leading, you're not following, but you are accompanying that patient in this process they're in. So, which of these three moves, attributing, interpreting, or moving with, do you find most difficult to practice? And what are the institutional conditions that make it difficult? I want you to hold that question. I know, now you have a whole list of questions I want you to hold, but that's okay. Make a note. I want you to hold that question because we're going to return to it when we get to the political dimensions of nursing knowledge. So we've arrived at Parse's theory of human becoming. And I want to begin by situating the theory properly because it's easy to approach. Parse is simply, if you think of Parse as simply another nursing theory, that it's just one of the options among many in a textbook of nursing theories, that would be a significant misunderstanding of Parse. Parse's theory represents something that's much more fundamental. It's a paradigm shift in nursing understanding and what human beings are, what health is, and what nursing is. So for Parse, basically, she developed her theory beginning in the 1980s, I believe, and drawing on Heidegger's existential phenomenological and Ponti's phenomenology of embodiment and Sark's existential philosophy. And the first comprehensive articulation of the theory appeared in her book from 1981, Man Living in Health. And she later changed it and renamed it to Human Becoming, and dropping the man for obvious reasons and keeping becoming because it's philosophically essential. So now Parse locates her theory within what she calls the simultaneity paradigm. And this is a key term. So the simultaneity paradigm, and it holds that human beings and their universe are mutual, simultaneous process. They're not separate entities that interact. They co-constitute each other continuously and simultaneously. The human being isn't a thing that exists in the environment. The human being is a process that is always already in mutual constitution with the world. So that stands really in sharp contrast to what Parse calls totality paradigm, and that paradigm, the paradigm that understands most nursing theories, including Roy's adaptation model, Orm's self-care theory, and Henderson's basic needs framework. In the totality paradigm, the human being is a biological, psychological, social, and spiritual entity who exists in an environment, who adapts to that environment, and who can be assessed and treated in terms of their functioning across these adaptations. Um, the nurse's role is to facilitate adaptation, to help the patient to move to a more adaptive state. In Parsa's simultaneity paradigm, that picture is inadequate. So the human being is not primarily an adapting organism. The human being is a free being, free in the philosophical sense, not in the political sense. So free means open and undetermined and creative. Human freedom is not a capacity that some people have more of than others. It's this ontological feature of human being. And nursing care in this paradigm is not about facilitating adaptation to some predefined norm that we've set. It's about being present to others freely, to their freely chosen ways of becoming. So, do you feel the weight of that shift? Take a moment. We're not talking about a different set of techniques. We're talking about different understanding of what a human being is. Okay, now let's unpack the specific principles of Parsa's theory because they're really philosophically rich and deserve careful attention. So, Parse, her theory is organized around three principles, and these principles are expressed in what she calls paradoxical rhythms. I want to spend a little bit of time on what that means because it's one of the most commonly misunderstood aspects of her work. Paradoxical rhythms aren't contradictions. They aren't problems to be resolved. They're the rhythmic structure of human becoming, the way that seemingly opposite poles are always held together in lived experiences. Let me give you the most important one: enabling and limiting. So, every choice that a human being makes simultaneously enables certain possibilities and forecloses others. When you choose to become a nurse, you enable a set of possibilities, a particular kind of work, a particular way of being in the world. And simultaneously, you foreclosed others. Not because anyone stopped you, but because choosing this means not choosing that. So, enabling and limiting are simultaneous, not sequential. And this isn't a problem. This is the structure of human freedom itself. You cannot be free without also being limited by your freedom. Another paradoxical rhythm is revealing and concealing. So we express ourselves when we speak, when we gesture, or when we're just present to another person. We are always simultaneously revealing something and concealing something at the same time. What we reveal kind of illuminates who we are, and what we conceal is not a deception. It's the inexhaustible depth of a person who is always more than any expression can capture. For nursing, the patient who is non communicative is still revealing and concealing. They're not empty, they are full of depth that our categories haven't yet found. And the third is connecting and separating. Every genuine connection also involves a moment of separation, the recognition that the other is genuinely other, not simply an extension of yourself. Compassion that compassion that obliterates the other person's oneness isn't compassion. It's a kind of absorption. True connection requires preservation of the ego, the acknowledgement that I cannot fully know what you are experiencing. And that is not a failure, but a condition of genuine meeting. Now I want you to do something. Think of a paradoxical rhythm from your own practice experience. Not Parse's examples, but your own. A situation where you felt the simultaneous pull of two apparently opposite things. Make a note of what that is for yourself, because it's going to help you interpret this, and it's going to help you make it real in your own mind. Parse isn't just a theorist. She's also a researcher, and she developed her own specific methodology for conducting research within her theoretical framework. The methodology is called Parse Research Method, and I want to walk you through the 4 stages carefully, because understanding the method helps you to understand the theory more deeply. The method and the theory really aren't separable. The method enacts the theory. So the first stage is dialectic engagement. This is data collection phase, but notice that she does not call it that. She does not call it interviewing. She doesn't call it data collection. She calls it dialogical engagement. Because the research isn't extracting information from the subject, the researcher's actually entering into this genuine dialogue with the participant about their lived experience and the phenomenon under study. The researcher brings no agenda, no preformed hypothesis, no structured interview guide. They just bring this open question. And it might be a question like, please tell me about, please tell me what it's been like for you to live through this experience. And then they listen. They genuinely listen, not waiting for an answer to fit a category, but attending to the particularity of the person's meaning making. The second stage is extraction-synthesis. This is the phase where the researcher works with the transcribed dialogue to extract the essential structure of the lived experience. It's a movement from particular to universal. So from this specific person's account to the general structural features of the experience. But this is really crucial. It's a movement that does not leave the particular behind. The structure must remain recognizable to the participants. It must speak their language while also speaking the language of the theory. And this is what Parse calls semantic consistency. The findings must belong to the same theoretical universe as the theory itself. And the third stage is heuristic interpretation. And here the researcher moves from the language of the participants to the language of the theory, explicitly relating the structural features of the experience to Parse's principles and concepts. This is where the theoretical contribution is made visible. So how does this particular lived experience illuminate, extend, or challenge the theory? And the fourth stage is writing the structure. The researcher articulates a structural description of what it's like to live through the experience, written at a level of abstraction that honors both the particular of the participants and the universality of the theoretical framework. I want to emphasize something about the rigor in this method. Rigor in the parse method's not about inter-rater reliability or triangulation with the quantitative data or member checking in the conventional sense. Rigor's about semantic consistency. Does the language of the finding belong to the same theoretical universe as the language of the theory? Is the researcher's interpretation coherent with Parse's ontological and epistemological commitments? And this is a different standard. It's not a lower standard, it's a different standard. And it's one that requires deep familiarity with the theoretical framework. Okay, so let's turn to the work of Jacqueline Fawcett, who is one of nursing's most important meta-theorists. Fawcett is the theorist who gave us the concept of nursing meta-paradigm, the four concepts of person, environment, health, and nursing that define the boundary of nursing's disciplinary knowledge. And in her 2004 work on theory of human becoming and action, she poses three questions that I think every nurse researcher should want and be able to answer about the theory they are using. And on a personal note, this was an amazing human being who recently passed. And when I was in grad school, I wrote a conceptual framework, and it combined some work of hers with some other work that I was doing. And here I was, a PhD student, and I emailed it to her and asked her if she would look at it for me. And this was a person who had never met me, didn't know me, and took time to give me careful feedback to something I later published. So know that these people live on through our work. So Fawcett's first question is, what does this theory tell us to do or to see differently? So this is a question of theoretical utility. A theory that does not change your practice in some identifiable way is not functioning as a theory, it's functioning as a decoration. So if you use Parse's theory, you should be able to say, before I engage with this theory, I did nursing like this. And after engaging with this theory, I did nursing like this. What is the difference? What's the change? That's the first question. Fawcett's second question is, when does the theory create friction with my institutional context? This is the question of theoretical tension. So Parse's theory isn't institutionally neutral. It makes demands on the nurse that may be in direct tension with the demands of the institution, with productivity metrics and with documentation requirements and with staffing ratios and with the medical model that dominates most hospitals and clinics. Fawcett's asking us, where does the theory create friction? And the implication is that friction isn't a reason to abandon the theory. The friction is a site of critical reflection. It's the place where theory and practice meet in this productive tension. Fawcett's third question is, have you modified the theory, and is that modification defensible? This is the question of theoretical integrity. Nursing theorists sometimes use a theory as a general inspiration, borrowing concepts, using language involving the name, without actually engaging with the theory's specific commitments. So Fawcett's asking, if you are claiming to use Parse's theory, are you actually using Parse's theory? And if you have modified it, which is sometimes necessary, it's what I did, well, not with Parse's, but a different one. can you defend that modification in terms of parser self would recognize as theoretically coherent? So when I made my modification to a theory, it was one that was developed by Fawcett when she was at the University of Connecticut. And so to use it and to modify it, she needed to tell me it was congruent. And since she was still alive at the time, she did. I want you to use these 3 questions as a template for evaluating any theory you encounter in your doctoral work. Not just parse, but any theory. Ask, what does it tell me to do or to see differently? Where does it create friction? And have I modified it? And how do I defend that modification? I'm going to move on now to nursing knowledge and human science. And I'm going to begin with what I'm going to call the philosophical manifesto of human science nursing. So it's a set of commitments that distinguish human science nursing from natural science nursing, and at a fundamental level. And I want to read these 4 pairs to you slowly, and I want you to feel the philosophical weight of each one. So first, understanding over prediction. Natural science asks, what will happen next? If X, then Y. And human science asks, what is happening? What does it mean? Understanding is not a weaker form of prediction. It's a different epistemological goal. It aims at meeting rather than regularity. Second, narrative over number. So neutral science represents reality through measurement and quantification. And human science represents reality through narrative, through the stories that people tell about their lives. Numbers are not wrong, but they don't capture what numbers cannot capture. And there's much more about human experience and that numbers cannot capture. And third, co-creation over control. In natural science, the researcher controls the experimental conditions in order to isolate variables. And in human science, the researcher acknowledges that their presence changes the situation and that the change is not a confound to be eliminated, but it's a feature to be understood. Knowledge isn't extracted from a passive object, it's co-created in a meaning between knower and known. Fourth, whole over the part. So in natural science, advances by analysis, by breaking down wholes into parts and studying their parts separately. And human science insists that the whole is not separate. It's not simply the sum of its parts. And that's something that can only be understood at the level of the whole. So a person's experience of dying cannot be understood by studying their cellular metabolism or their cortisol levels or their family history or their religious beliefs separately and then adding them up. It has to be understood as a unified lived experience. So I want to ask you something that I think is genuinely important. These 4 commitments, understanding, narrative, co-creation, and whole, aren't simply methodological preferences, they're ontological commitments. They encode a view of what human beings are. And here's the question. What ontological commitments are built into the standard nursing assessment Well, let's be more specific. What ontological commitments are built into the standard nursing assessment form that you might find in an electronic medical record that you use in a practice setting? When you fill in the standard assessment, what kind of human being are you implicitly assuming you are assessing? And is the assumption visible to you, or has it become invisible through familiarity? Let's turn to a piece of writing that I think's important, an important critical intervention in nursing theory in the last probably 30 years. So in 2002, there was a paper by Gary Mitchell and William Cody that was titled Nursing Knowledge in Human Science, Epistemological Considerations. Mitchell and Cody are arguing something that has political as well as philosophical dimensions, and I want to make sure that we attend to both. So the central political argument of the paper is this: the hegemony of neutral science in healthcare is not simply an epistemic claim. The claim that natural science methods produce better knowledge. It is a political argument that gatekeeps those knowledge counts. When a piece of nursing knowledge is dismissed as soft or anecdotal or mere philosophy or impractical jargon, it's not being refuted, it's just being excluded. There's a difference between refuting something and excluding it. Refuting engages with the content of a claim and shows it to be false or inadequately supported. And exclusion kind of sidesteps the content and uses social power to deny the claim's legitimacy. So Mitchell and Cody are naming the fact that a great deal of what passes for epistemological debate in nursing is actually exclusion, masquerading as refutation. So the second argument is what I'll call the no view from nowhere principle, a phrase borrowed from philosopher Thomas Nagel. The claim is that there's no epistemological vantage point that is not already shaped by particular ontological commitments and values and interests. So the nurse who insists that only randomized controlled trials produce valid nursing knowledge is not taking a neutral epistemological position. They're taking a deeper loaded ontological position that are implicitly claiming that the aspects of human experience that can be captured by a randomized controlled trial are the aspects that matter, and the aspects that can't be captured do not matter or matter less. This is not neutrality. This is a choice, and it should be named as a choice. So I'm curious if any of you had their scholarly language dismissed as jargon, or has someone said to you, that's very theoretical, but what does it actually mean in practice? What happened when that happened? How did you respond? And what would you say now, having heard Mitchell and Cody's argument? So Carper's fundamental pattern of knowing is kind of an epistemological framework, and it's a foundation. It's kind of foundational for nursing knowledge theory. Barbara Carper's fundamental pattern of knowing is something that you're reading. So Carper's paper was published in 1978. Um, in the first issue of the Journal of Advances in Nursing Science, and it remains nearly 50 years later one of the most cited papers in nursing theory. So it's worth spending real time on it and reading it carefully. Carper identified four patterns of knowing in nursing, four distinct but interrelated ways that nurses know what they know and do what they know. So, and do what they do. Sorry. The first pattern is empirical knowing. So, the science of nursing. This is a pattern most familiar from biomedical education. Systematic, testable, replicable knowledge organized into theories and then confirmed by research. Clinical guidelines, evidence based protocols, pharmacokinetics, all of this is empirical knowing. The second pattern is ethical knowing, the moral component. This is the nurse's knowledge of moral principles, ethical frameworks, and the values that should guide nursing action. It's not the same as following hospital policy. It's the nurse's own developed capacity for moral reasoning. The third is aesthetic knowing, or the art of nursing. This is the nurse's ability to perceive and respond to particularity of a situation. Um, it's to grasp what is needed in the moment with this person, this patient, in a way that can't be fully specified in advance by rules or protocols. So it's the knowledge that makes expert nursing kind of look like artistry. And the fourth pattern, and this is the one we're going to spend most of our time on, is personal knowing. Carper described personal knowing as the most problematic and the most essential of the four patterns. If it's the nurse's knowledge of themselves as a person, their capacity for authentic, full person engagement with another person. And Carper was explicit that this isn't a soft skill or a nice to have skill. It's a constitutive element of nursing knowledge. So before I say more about personal knowing, I want to note that Carper's framework has been extended and contested by later scholars like White, who added a fifth pattern of socio-political knowing, and Chin and Kramer have developed a comprehensive emancipatory framework. Moonhill explicitly engaged with unknown knowing. So this shows that Carper's framework is alive, and it's a living philosophical tradition, not a fixed monument. And that's how it should be. So pay attention to these four types of knowing, empirics, aesthetics, ethics, and personal knowing. Um, let's move on to the 2020 paper by Sally Thorne that was published in Journal of Nursing Philosophy, Rethinking Carper's Personal Knowing in the 21st Century. The paper is kind of a critical intervention, and I want to be clear about what kind of criticism she's making, because it's nuanced one that's easily misunderstood or misread. Thorne's not anti-qualitative. She's not arguing for a return to positivism. She's not dismissing the value of the subjective experience in nursing knowledge. What she's arguing is that the way personal knowledge has been interpreted in some quarters of nursing theory has introduced kind of a dangerous epistemological instability into the discipline. So, I think one way to explain what she means is the danger she identifies is what I'll call privatization of knowing. If personal knowing is understood as the nurse's unique subjective experience, their personal truth, their authentic self expression, and if that personal truth is understood to have epistemological authority simply because it's authentic, then we have a problem. Because personal authenticity by itself is not a criterion for validity. A nurse who holds deep personal convictions that contradict the best available evidence is not exercising personal knowing in Carper's sense. They are exercising personal opinion and calling it knowledge. We see way too much of this today all over the country in all manner of issues. So Thorne gives a deliberately provocative example. The nurse who refuses to recommend vaccinations to patients because of their personal beliefs about vaccine safety. This nurse might claim that they are experiencing personal knowing, expressing their authentic lived experience of the world. But Thorne's argument is no. Personal knowing in Carper's sense is disciplined. It's always in dialogue with empirical knowing, ethical knowing, anesthetic knowing. It is never a license to pursue private conviction in isolation from the other patterns. The deeper point is about epistemic accountability. Genuine nursing knowledge, including personal knowing, must be accountable to something beyond the individual nurse's subjective experience. Not because subjective experience isn't important, it is, it's essential, but because unaccountable subjectivity is not knowledge, it's something else. So here's my question for you. Is Thorne right? Are there limits to epistemological pluralism in nursing? And where should those limits be drawn? And this is the important political question. Who has the authority to draw them? All right, we're close to the end for today. I know, I'm a little long-winded, but I want to take a somewhat different approach here. A turn into literature and existential philosophy because I think it kind of illuminates something about nursing encounter with death and dying that more technical philosophical language sometimes obscures. I want to begin with a question from an Argentine philosopher and writer, Borges. So he was one of the 20th century's greatest writers and poets. And he was also, in a serious way, a philosopher. He used fiction to explore questions that academic philosophy sometimes struggles to articulate. And the question I want to share with you is, on the banks of the Rhone, I was reminded that time is a river and I am the water. Let's just sit with that for just a moment. The image, the human being as water in the river, not a stone on the bank, is the image of self as process. I'm not something stable that time flows around. I'm part of the flow itself. And this has profound implications for how we understand death. If I'm the water in a river, then my death is not the destruction of a substance. It's the transformation of a process, a change in the form of flow. So there are philosophers who argue directly with Borges in this context. Hege Kenan was an Israeli philosopher who works at Tel Aviv University, and Kenan's reading of finitude challenges the dominant existential phenomenological account, which is Heidegger's, um, um, of being toward death. So Heidegger, uh, death is the possibility that is uniquely mine. No one can die my death for me. Death individuates. It separates me from the crowd, from the they self, and it confronts me with my own most non relational possibility. Death in Heidegger, it cuts me off from others precisely in the moment of my most authentic self confrontation. Kennan, and through him, Borges basically argue the opposite. Finitude becomes real not through the anticipation of my own death, but through the encounter with the death of another. It is when I'm at the bedside of someone who is dying that I first truly understand what finitude is. And this understanding is not isolating, it's relational. It binds me to the other person. It makes the other person's departure an event of significance to me. And for nursing, this has an immediate implication. When we accompany the dying, we're not observers of a biological event, we're co-witnessing. We're participants in the event of mutual finitude. We're not safe on the bank watching the river. We're the water too. And knowing that, being willing to know that, changes everything about how we present at the bedside. It changes what we say, it changes what we don't say, it changes the quality of our silence. So how does this understanding change what you say or don't say at the bedside? What would it mean to be a co-witness rather than an observer at the end of life? At this point, we can see how process philosophy reshapes nursing science when compared with traditional positive or totality paradigm. So let's begin with the view that the human being in the positive paradigm, the person is understood as a biopsychosocial spiritual organism that can be analyzed through its component parts. In the process or simultaneity paradigm, the person is understood as an open being who continuously co-creates reality with the universe. Then next, we consider reality itself. The positivist view assumes reality exists independently and can be objectively measured. And the process perspective argues that reality emerges through mutual human-universe processes. Meaning and experiences are inseparable from what is real. Health also changes significantly. In the totality paradigm, health is defined as equilibrium or conformity to population norms, and in the process paradigm, health is understood as the person's lived process of becoming, regardless of whether disease is present. The paradigms also differ in what counts as knowledge. Positivist knowledge seeks generalizable and predictive explanations, and process-oriented knowledge seeks to reveal meaning within particular lived situations. The differences naturally influence methodology. So positivist approaches favor experiments in correlation and randomized controlled trials, and process approaches favor phenomenology, hermeneutics, and dialogue-based inquiry. And finally, the nursing goal changes. The positivist goal is to prevent disease, restore function, and promote health. And the process goal is to create quality of life as defined by the person, recognizing that the individual's meaning and values are central. And as you review this table, consider whether the greatest tension exists in your own practice or research setting. Is it how health is defined, what counts as evidence, the goals of nursing care? Those tensions reveal where process philosophy challenges our existing assumptions most deeply. Let's talk a little bit about research implications and clinical integration. And I want to begin with what I think is most particularly or practically important, is that the research question is an ontological act. When you formulate a research question, you're not making a neutral methodological choice. You are making a commitment about what kind of thing you think you are studying. Consider these two research questions. Okay, research question 1. Does guided imagery reduce pain scores on a numeric rating score in post-surgical patients? And the second is, what is it like to live through the experience of post-surgical pain? So these two questions are not simply studying the same thing from different angles. They're studying different things. The first question assumes that pain is a measurable state. It's a property of a subject that can be quantified and reduced. The second question assumes that pain is lived experience, that it's a meaning-laden, temporally extended process that has to be understood from outside. Neither question's wrong. They can't be reduced to each other, and the choice between them, or more precisely, the choice of when to ask which, is an ontological choice. It's the choice about what kind of thing you take the patient's pain to be. If you're working within a process ontological framework, if you're using Parse's theory or Thompson's inactivation or Dupree and Nicholson's approach, then there are 5 dimensions of your research design that will be affected. The research question will be formulated in terms of lived experience, meaning or process rather than variables and states. The theoretical framework will be a process-oriented nursing theory or a comparative phenomenological framework, not a theory that assumes substance ontology. The method will be a method that's designed to honor the irreducibility of the lived experience. The Parse method, interpretive phenomenological analysis, narrative inquiry, not a method designed to measure and aggregate. The criterion for rigor is a classical sense, but semantic consistency, theoretical coherence, and resonance with participants' own meaning making. And then, of course, the dimension strategy will be attentive to the way findings are communicated, not as a list of variables or outcomes, but as a structural description that kind of illuminates the lived experience in its fullness. So here's a thought for you. Take a research question you've encountered in the readings from anywhere in your program, from an article or a textbook or colleagues, and now formulate it using an ontological framing. And what changes? What becomes visible that was invisible? and what, if anything, is lost? And that's something for you to work on. So, what does it mean to live this experience? And the research question kind of is your foundation. Um, so think about the research question, the participants, the data you're collecting, the analysis, and the rigor. Let me bring the theory into direct clinical contact through a vignette drawn from Parse's own writing. So, this is a real encounter, a real nurse, a real patient. And I want to walk through it slowly because it illustrates more powerfully than any abstract statement what the difference between substance based and process based nursing actually looks like at the bedside. The patient uh, basically, let's call him Mr. A. Um, he's an elderly man admitted for cardiac procedure. He's lying in the bed, and a nurse notices that he's not sleeping. He's alert, his eyes are open, and he is shifting in bed. From a substance based framework, the nurse might immediately categorize this behavior. The patient appears anxious and agitated. This is a behavioral state. So, what are the interventions for anxiety in a post procedure cardiac patient? The nurse might offer medication, reassurance, structured relaxation technique. And the nurse might document patient displaying anxious behavior, intervention initiated. Now let's watch what the nurse using Parse's theory does. The Parse-informed nurse does not first categorize. The Parse-informed nurse is curious. She approaches Mr. A and asks, I noticed you aren't sleeping. Can you tell me what's going on for you right now? And Mr. A says, I'm cold. He was cold, not anxious, not agitated, cold. Now, I want you to think about this carefully. The substance-based nurse was not making an error of clinical reasoning. From the outside, from the perspective of observable behavior, the presentation was consistent with an anxiety, but the behavior was not anxiety, it was cold. And the only way to know that was to ask, to hold the question open, to resist the closure of categorization long enough for the person to answer. That is what Parse calls the nurse-person process. And it begins with a specific philosophical orientation, the refusal to know in advance what the other's person experience is. It begins with a genuine not knowing, not as a deficiency, but as an act of respect for the other person's irreducible subjectivity. The clinical stakes here are not trivial. A substance-based nurse who medicates for anxiety when the patient's simply cold hasn't just made a minor error. The nurse has failed to see the person in front of them. She or he has treated a category rather than a human being. So, what would the substance-based stance have done next if Mr. A had not spoken? And what did the process-based stance make possible by holding the question open? So remember, judging in the flow, 3 moments of clinical judgment. First, you notice, then you interpret, and then you respond. So the clinical implications, step 1, further address a question that I think really is an important one and one of the most philosophically interesting questions in contemporary nursing. Can quality of life be standardized? Just sit with that question for just a moment. Can quality of life be standardized? Most healthcare institutions operate as if the answer is yes, or at least as if it has to be yes for particular reasons. We use validated instruments like the SF-36, the PROMIS suite, the EQ5D, um, and these instruments have been developed with great care. They've been tested across large populations. They've shown to be reliable and valid and in the classical sense. And they're genuinely useful for a certain purpose. But let me ask you to think about what these instruments are doing philosophically. A quality of life instrument is a measurement device. It assumes that there is a property called quality of life that varies across individuals and that can be captured by asking certain questions and aggregating the answers into a score. It assumes, in other words, that quality of life is a state. It's something that you have in some amount at a given moment in time. It is in this sense a profoundly substance ontological instrument. What happens to quality of life if you think about it from a process ontological perspective? Quality of life isn't a state. It's a process. It's the ongoing experience of living, the way a person is unfolding in relation to what matters to them, to their relationship, to their sense of who they are and who they're becoming. So it's not something you can capture with a questionnaire at a single time point. It's something that's always already in motion, like the river. Parses' theory offers an alternative. Ask the person, not on a scale of 1 to 10, how they would rate their quality of life, but what's the most important thing to you right now? What is giving your life meaning? What's difficult? What are you hoping for? The questions don't produce a score, they produce a conversation. And that conversation, that genuine dialogue between nurse and patient, is itself a form of care. If you had to design an outcome measure consistent with Parses' theory, so a measure that honored the procedural, the relational, the meaning-generating nature of human experience, what would it look like? Now, I don't expect you to solve this problem in the next 5 minutes, or maybe in this course, but I want you to understand that it's a real problem and that the solution will require exactly the kind of philosophical thinking we've been doing here today. So, can quality of life be standardized, or can it only be co-defined? Something for you to think about. So let's model explicitly the dialectical reasoning that has been the structural backbone of this lecture and walk through it. The dialectic I want to work through is the one between nomothetic and idiographic knowledge in nursing. So nomothetic is relating to the foundation of general laws. Idiographic is relating to the study of an individual case. So here's the question, the thesis for you. Nursing knowledge must be nomothetic. It must be generalizable. It must be based on evidence that applies across populations, because individual variations, while real, is noise around the signal. And the signal is what we need to build reliable clinical protocols. evidence-based practice is only possible if we have evidence that transcends the individual case. But nomothetic knowledge, nursing becomes a collective of antecedents. It can't justify its practice claims. It can't contribute to health policy. It can't defend its intervention. So the thesis is generalizable. Here is the antithesis. And nursing knowledge must be idiographic. It must attend to the irreducible particularity of the individual human being, because the patient isn't an instance of a population. The patient is a specific person with a specific history and specific relationships, a specific experience of illness that can't be captured by any general law. Evidence-based protocols are averages. They describe what works for a statistical abstraction, not necessarily for the person that is here and now. Without idiographic knowledge, nursing care becomes a processing operation. It can't honor the person in front of it. It can't respond to what is actually happening rather than what the protocol predicts should be happening. So before I show you the synthesis, I want you to think about what you would propose. So genuinely, what synthesis would you offer? And how do you hold these two positions together without simply splitting the difference? So for me, here's the synthesis. Nursing really does require disciplined pluralism that's grounded in shared values and specific to context. Nomothetic knowledge provides the best available evidence about general patterns. It's essential, and ignoring its not idiographic nursing, it's negligence. Idiographic knowledge provides the ability to apply the evidence to a specific person, to understand how the general pattern is being lived in a particular case. The two do not compete. They operate in different levels. So the synthesis is not sometimes do one and sometimes do the other. The synthesis is that every nursing encounter requires both, operating simultaneously in genuine dialogue. The skill that makes this possible is exactly the kind of philosophical thinking, the dialectical thinking that we have been practicing today. So I want to offer you 4 reflective prompts that are designed to help you integrate what you've encountered today into your own thinking and your own practice. And these are not rhetorical questions. They're genuine prompts for reflection, and I want to spend a few minutes on each one of them. So first, what in your practice do you rely on with a substance ontological view of the patient? And what would change if you shifted to a process view? And let's be specific here. Not in general, the biomedical model is substance-oriented. Think of specific practice, a specific assessment, a specific documentation habit, a specific way of talking about patients and handoffs or reports. Where exactly does substance thinking operate, and what specifically would you do differently? And second, where have you confused stability and substance? This is more personal, more difficult question. Have you ever treated a patient or a colleague or yourself as if the current state was simply what they were, as if the person who is grieving is a grieving person? Just full stop right there. Rather than a person who is currently in the process of moving through grief, where have you kind of reified a process into a substance, and what was the cost? Okay, third, what would it mean for your practice to be a co-witness rather than observer? So borrowing from the discussion of Kenan and Jonas, in the moments where you are present to someone else's vulnerability, their pain, their dying, their fear, are you observing from a professional distance, or are you genuinely present as a co-witness? And what does genuine co-witnessing feel like? And what does it cost? What does it make possible that observation can't? And then finally, what's the most important unanswered question that you have from this lecture? So think about specific questions that you may have. So let me connect these reflective prompts to the reading from the course. The Mitchell-Cody paper will help you think about prompts 1 and 2. It names the political conditions that make substance thinking the default. Thorne's paper will help you think through prompt 3. It makes what accountability looks like in human science nursing. And the Thompson and Kenan readings will help you think through prompt 4. They point toward the most generative open question in the philosophy of nursing. And for your assignment, dialectic means taking a defensible position. I know, we say this every week. Not finding the safe middle, not surveying all the perspectives without committing to one. Dialectic means, here's my thesis, here's my strongest objection to it, and here's my synthesis, which reframes both. That's what I'm looking for. Here's some takeaways for you. First, process ontology provides nursing with a philosophically coherent account of human being that honors the irreducibility of lived experiences. And this is a foundational claim. It takes only one thing from today. Take this. Human beings are not things. They are processes. And there isn't a poetic metaphor. It's a metaphysical claim and with clinical and research implications. Second, Parse's theory of human becoming is the most fully developed application of process philosophy to nursing. It's not the only one. Newman's work, Watson's work, and others are relevant, but it's the most philosophically rigorous and the most directly connected to the tradition we have traced today. Third, dialectical reasoning is the philosophical skill that makes it possible to hold the tensions between nomothetic and idiographic, between empirical and interpretive, without collapsing into one side. It's the skill this lecture has been practicing, so keep practicing it. Nursing knowledge is politically situated. As Mitchell and Cody argue, epistemological debates are not neutral. They encode power relations. Knowing whose knowledge counts and why it's part of being in nursing, why it's part of being a nursing scholar. Let me repeat this. They encode power relations. Knowing whose knowledge counts and why is part of being a nursing scholar. Fifth, personal knowing. As Thorne reminds us, it is not a license for unaccountable subjectivity. It's disciplined, relational, accountable to the community of nursing knowledge. Pluralism has limits, and those limits are defined by shared values as a discipline. And finally, sixth, to accompany another human being in illness and dying and in vulnerability is to be a co-witness. It is to acknowledge your own finitude in the presence of theirs. And it's one of the most philosophically serious things a human being can do. I'm going to close with the phrase we began with, Ponte Re, everything flows. You, me, this lecture. Borges wrote, on the bank of the Rhone, I was reminded that time is a river and I am water. And I want to leave you with the question that this image raises. If you are water in a river, if you are not standing safely on the bank watching the current pass, then where are you? What river are you in? And who is flowing alongside you?